So the first question was from Joe Gurden, who asked, regarding margin HTFD measurements, I saw that the VCPG recommended not providing any decimals in the measurements. In that case, I would assume that you would always round down in your report, i.e. 2.6 millimeter margins would be reported as 2 millimeters. This gets tricky when the measurement gets smaller. How would you report a measurement of 0.4 millimeters or 0.9 millimeters? Thank you. And so I'm not sure who would like to address that from our panel.
I guess I can make a comment even though I wasn't presenting that part. I always just have a rule to round down anyway, regardless of how small that measurement is. I think we kind of just, we have to call out the fact that most times we're only seeing at most 3, 4, 5 sections of an entire tumor. And so the fact that we have one margin that is 0.4 millimeters in one area versus 0.9 in other, it doesn't mean that there is another section where it could be even less than the 0.4. So I guess that's where I would go with it, because I would rather earn the caution that maybe 0.4 isn't significant enough for me to worry about whether it's rounding up or down. To me, that's pretty small margin, and maybe just reporting that would be enough. So that's my opinion.
I'll have a go at that. It's Rob Foster here. So I always try to be guided by the peer-reviewed literature. So it really depends on what tumor you're dealing with. Now, in some cases, there are studies that show that if there is any histological tumor-free distance, the likelihood of reoccurrence is very low. And so in that case, differentiating between tumor at margin and tumor not at margin may have some significance. If there is, and I go based on published information first. So if there is any distance, our ability to relate the distance that we see histologically with that grossly, I would be inclined to say, for example, less than 1, and then to round down. So, and that is not based on any specific literature unless I know I'm dealing with a situation where there is a statement about it. So there is information about it on subcutaneous mast cell tumors, on soft tissue tumors. They're just 2 where there is some information. So I would go by that. And everything, every question I have or every answer I have is first of all guided by what's in the literature and is that a reasonable study. So it's not answering your question directly, except that, go on what's published.
This is Don. Can you hear me okay?
Yes, Don.
I think when we came up with that recommendation of not to use decimals, it was based on the idea we'd be implying a level of precision that we really can't deliver through the scope, or I'd have to defer to Richard and Eliza for WSI. I'm sure they could do dot to dot and actually get a pretty specific number. But then I really like Rob's answer, which is, it depends on the tumor, and it's time for us to learn from our prior studies, although they could all use some improvement. I mean, if it's a mast cell tumor, even if there's tumor cells at the margin and it's low grade, they don't recur. If it's high grade, Donnelly et al. Couldn't determine a safe margin or histologic tumor-free distance that predicted it would not recur. So who the tumor is really does matter, but I think we need to be careful because of shrinkage, because of so many things that we now know today, that to start to report things when they're less than 1 millimeter, that's pretty iffy. But I remember the specific question. I think she even said 2.9. Give me a break. That's got to be 3. And the folks I speak to at the microscope companies have told me, Don, our scopes are so precise. We're better than you with a stage micrometer. So I think when you get to that precise a number, let's not get the clinicians thinking that it's really important. I'd love to get them to put ink on the specimen, and then we can say that it does or doesn't touch the ink. Eliza, sorry.
Oh, no, it's okay. Sorry, Don. So the other thing I think we need to also consider is, okay, so we have it under a microscope and we can measure it, but what happened to the sample beforehand? Was it fixed right away? How was the sample? Was it under a heat lamp with the patient? How was it processed? What temperatures was it processed? Was that standardized? What were the exact levels of alcohol and xylene to cause the shrinkage? And so, again, I think adding that decimal point adds a level of precision that is not reflective of what happens to the tissue.
Yeah, one of the questions that I ask clinicians when they contact me and they say, "Is it clean?" I ask them about their surgical dose, and if the surgical dose, if they were aiming for most of the time when I get that question, there's this silence on the other end of the telephone. Like, what do you mean by surgical dose? What kind of margins did you take? And if, you know, if I'm looking at something that's less than 1 millimeter, and I know that, you know, it can be measured, but the significance of that, I think, is what is important. And you're right, when it's down, you know, so small, and if their attempted surgical dose was 2 centimeters, 20 millimeters, and they got 2 or they got 1, what difference does it make? Unless there is published information to show that, you know, between 1 and 3 millimeters, there is, you know, this percentage of likelihood of recurrence. So I think I agree, we are measuring to an extent that we can, but we're kind of losing sight of the clinical significance.
I think just because we can measure it, Rob, doesn't mean we should necessarily report that precision. And I think it may be time to start to add to our reports, hey, look, there is a gap, and that gap is greater than what I'm telling you because of shrinkage and what Eliza was saying.
Yep.
I have a quick question, if I could intervene here. Sorry, this is Taryn. Great job, everybody. These have been great talks and discussions. I just was wondering, to the clinicians, how do you interpret less than 1 millimeter? And should we be using that? Because I think that is very widespread. And what does it actually mean? What are we trying to say there with less than 1 millimeter? That we think the tumor cells are really, really close, but there's a tiny, tiny, you know, there's a possibility that they might not be going all the way. You know, I just want to know thoughts about that.
Go ahead, Michelle.
Exact same time. I guess I would say from my perspective, for me, less than 1 millimeter is dirty. Anywhere, because I'm assuming in that case that there's probably tumor cells crossing the margin somewhere else that I haven't been trimmed in. And so when we're getting to that level of extent, depending on the tumor itself and the general pathology and kind of where our concerns are, for me, realistically, when we get to that point, I tend to treat it as a dirty margin, but I don't know what Ryan thinks.
Yeah, I treat it the same way.
We should probably remind everyone too that, what do we see, less than 1% of the total margin? So what Michelle said is very appropriate, but if we sample it someplace else, we may get a different number.
Yeah, I mean, I'm just curious, you know, should we be just rounding that down to 0 or, you know, I don't know. I don't have an answer. I just think it's an interesting discussion, and probably, you know, unless we try to change it, we'll continue. But, you know, Jamie had his comment about if it's 0.9 millimeters and less than 0.1 millimeters, it does look a lot different under the scope. So, you know, maybe that's the reasoning for continuing with that that phrase. But, you know, I just think it's a discussion that we need to have and try to standardize as much as we can.
Okay, thanks everyone. On the topic of margins, Dr. Rebecca Smedley had a question as well. She asks, how do you account for the potential of asymmetric growth when reporting HTFD when only 1 or 2 sections of a tumor are evaluated? If a clinician does not know or understand how a tumor is trimmed, are you worried about giving them a false sense of security by reporting an adequate margin in that single section?
Hi, everybody. This is Rebecca. I was just about to jump in because based on what Don just said too, like, we know you're only looking at 0.1% of the tumor. So I just wanted to hear some perspective on that from both like Rob as well as the clinicians too, and how they interpret that.
I'll make a comment, but I'll very quickly hand it over to the clinicians because they are the ones who determine whether it is an excision is adequate or not. And if there was a particular area of concern, that is an area that they are advised to ink. So I guess the answer is it really depends on the surgical dose. It depends on the location. It depends on areas of potential interest, and those factors are taken in with all the animal factors for determination. There is always that issue, regardless of how many sections are taken and whether you do you know, the type of sections you do, because we don't sample the whole thing. We are only ever trying to estimate. And after that comment, I'll hand it over. If someone else, one of the clinicians, one of the surgeons wants to make a comment, I'd be free to do so.
I guess for me, it comes down to my impression first and foremost. So yeah, I kind of know when I have a case where I'm concerned about if margins are going to be close or not. And so I'm already sort of anticipating from the pathologist that they're not going to be complete, or, you know, I'll indicate that on my requisition form. So I do really appreciate, Rob, that you sort of call the clinicians out when they call to seek guidance about, you know, hey, are my margins clean or not? So I think the impetus really needs to be on us initially to kind of give the pathologist guidance about our expectation. And I never, you know, get one of those biopsies back where I'm nervous about margins. And if it says, you know, the tumor extends to less than 1 millimeter from the edge, I say, oh my God, you know, I'm so happy I got complete margins. You know, we know that is likely incomplete somewhere else. And so we just have to, you know, assess the biologic behavior characteristics of the tumor and appreciate what's going on with the patient, and then assimilate that into the path report. It can't be sort of this static piece of information that you guys give us, and then, you know, we go and celebrate when you say we got it completely removed. You know, there's been several instances where it says complete excision, but I say, you know, there's no way that I got that completely removed. So can we go back and cut in more sections to take a look? I guess that's my take on it.
I totally agree. And I think the other part for me is I think it becomes important when we talk about who's interpreting that margin assessment. So that's where if we can have a more objective, just this is the distance, and not necessarily that the pathology report is reporting what they consider the completeness, but just giving objective findings. Because what I find often too is when we get into general practitioners, they look at the pathologist report who in some cases says complete margins, and then even goes as far as to next say, and here's the prognosis and here's how you should address it. And we can run into real trouble. You know, I've seen a lot of those where it's like, I vehemently disagree with the way that that's been interpreted. And I don't think you can make a lot of interpretation around some of this information without having been the clinician who was physically doing the surgery. And so I think that's where we have to be very careful in how we provide that information, because there's a big difference between, you know, an incomplete margin where one spot has tumor cells close to the margin and an incomplete margin that has tumor cells everywhere, or a complete excision where no margins were actually, you know, tried to be obtained. And so from a surgical bed perspective, it may not be complete, even if it appears histologically complete.
I was just going to say, I think it's also important to include in the pathology report how the tissue was trimmed so that clinicians do know what kind of sections were taken. Was it one representative section? Were they radial sections? We offer like a full margin study where we do radial sections with measurements as well as tangential sections. So tangential, those orange peel sections all the way around. And we do charge more for that because you know, Rob said there's no way we could survive if I mean, sometimes we have like 80 slides on a case. So we definitely charge for that kind of thing. But I think we just have to remember we really need to educate more so like the general practitioners in how these sections are trimmed and how the margins are evaluated so that they understand what data we're giving them. I think with the specialists, there's, you know, more of that understanding, but I think it's still lacking in some of the general practitioners.
I think a take-home point is that what we're doing is we're taking a three-dimensional structure and making it 2D. And so we're only taking a slice of the bread loaf. And it's not even a full slice sometimes. And so we may or may not get that nut that's in that like whole wheat bread. And so that's where the understanding has to come, 2D interpretation of a 3D structure.
We probably also need to look as a group in evaluating, are you more likely to get incorrect margins or more likely to have invasive growth on some tumor types than others? And I don't think that we've really investigated that to any great extent, but looking at that across a wide range of tumors to find out, are there tumors where we probably need to look at more sections versus are there tumors where the standard you know, cross-section and lateral margins is sufficient? That's probably something we need more research on.
Mike, to your point, there was that splenic paper. Don't know if you saw that, the difference between 7 sections versus 10 sections and the sensitivity and specificity of finding hemangiosarcoma if it was there. I thought that was a really good study and we need more of those.
That was my paper.
Okay, thanks for that really interesting discussion, everyone. Now moving away from margins, we had an anonymous attendee ask, are there known substances in the tissue barriers or fascial planes that prevent migration of tumor cells through them, such as cytokines, chemokines, etc., or is it purely a physical barrier? Thanks.
That's got to be a Milan or Rob answer. I'm only aware of one study that looked at that in human colonic carcinomas, but I don't think they identified any factors. They used an in vitro system. But Rob, Milan, do you have something?
The only comment I'll say about that is that we were very careful in our presentation to say potential and anticipated, and not to say that the tissue barriers, the compartment boundaries are absolute. It's used as a guide, and from a practical point of view, then experience over the last, the first talk about compartment boundaries and fascial planes was over 40 years ago. And while there have been some studies, and certainly there's knowledge about metalloproteases and movement of neoplastic cells through blood vessels, for example. Those kind of studies are available. I'm not aware of any specific, certainly not in animals, where a particular barrier has been examined to that extent. And I wouldn't expect it to be done either, because there's a risk reward here, and it's an extremely expensive procedure to kind of look at those factors potentially in barriers that vary so tremendously, and in tumors that vary so tremendously.
It's an interesting question, though, isn't it? That if the epimysium is a functional barrier, it seems logical that there's got to be a substance in there that prevents the migration of the tumor cells. And of course, that's probably going to vary with the degree of aggression of the tumors as well. But it doesn't matter what part of science we started with, we make these simple observations, and then 10 years later, someone identifies the cytokine, interleukin, or the other substance that helps explain osteoclast activating factors and so forth. I really liked what you guys presented, though, with facial planes, Rob and Milan. It was very, very interesting. Look forward to Milan's video.
Okay, thanks everyone. There were a couple of questions which were also posed and have been answered by separate people, but I think the questioners wanted them posed to the panel as well. So I'll ask some of those. So Dr. Fernando Constantino Casas asked, what is your opinion about looking at what is called tumor bed biopsies?
I'll be glad to tackle that one, Laura, because I bet we'll get a lot of hesitation. But if somebody else has experience with the terminology tumor bed, oh my gosh, interrupt me and save my embarrassment. I'm not aware if we use that in vet medicine. In human oncology, they'll use it for breast tumors. And apparently what they'll do is design their standardization of how many samples will they take, 12, 18, and so forth, to try to determine, is there residual tumor left in the bed? I think the only thing that compares that I know in vet medicine is a Bacon study, where they went back and looked at unplanned soft tissue tumor, soft tissue sarcoma excisions, and looked in those to say, and now I'm going to use that term, in the tumor bed, could you find tumor? Well, we don't standardize how many sections we should go look at, i.e. like with the hemangiosarcoma study or with these human breast tumors. So whoever posed the question, I don't know if that covered it, but you may want to ask, are they referring to breast carcinomas in humans, or was there a veterinary study? If there's a vet study, oh my gosh, send it to me, please.
Hey, Don, the only thing I see are usually re-excisions from dirty margins. I'm not sure that that really correlates.
Yeah, I don't know either if that's what the question referred to, but it could be. And we really need help with that, don't we? With contaminated margins, dirty margins, how do you go about reevaluating those? How many samples should you take before you say, no, there is no tumor present?
I'll make one comment here. I have seen tumor bed biopsies sent in from surgeons who were dealing with a neoplasm where they couldn't get a deep margin. So it was a skin tumor, subcutaneous, I think it was subcutaneous tumor. and there was no deep fascial plane. And so what they did was they did the kind of scooping out as best as they could, and then they took as deep as they could, and they submitted a separate sample as a tumor bed biopsy. And so that was looked at with the view to, yes or no. And it's a bit like the tangential section rather than the radial section, only it's a deep margin. So I've come across several of those. It's not something I'd consider routine, but perhaps one of the surgeons would like to comment about, that approach. I know in general, most surgeons try and go for the deepest that they can get, even if they can't get a deep fascial plane. But I have seen those samples, and perhaps there's something in the surgery on that particular situation where they were unable to do that initially.
The same thing, Rob. We see them not added frequently where clinicians will just say, I'm also submitting a little piece of the deeper tissue that we took after we removed the mass. To evaluate those, we typically red loaf them just to try to increase the area that we're examining. And we figure, if we're going to find tumor cells in that they're usually fairly small. If there's tumor cells in that little deep section that they submit, then we would consider that inadequate. So.
And I would agree from a clinical perspective. I think sometimes if we have, a region, let's say you've done your tumor excision and then you go back and you're looking at your tumor bed and you see an area where you're like, I don't know if that tissue looked quite right. Sometimes we'll take kind of an additional piece of tissue, mostly just to submit and sort of say like that didn't necessarily appear continuous with the rest of the tissue, but I'm concerned that this doesn't look like normal tissue. But I think at that point, at least from my perspective, I would never be expecting that there'd be any sort of assessment of a margin or anything on that, as much as just to tell me, is there cancer cells in that tissue or not, to help with guiding consideration for, adjunctive therapy.
Yeah, and I personally would take the approach that Milan described, where if, I try to correlate that deep area that I'm concerned with the excised block of tissue, and then I will ink that accordingly to have the pathologist actually pay particular attention to that region. So one thing that would be really kind of nice regarding standardization is to, have clinicians all sort of do the same thing when we're submitting tissue, to have pathologists cue into a certain area, because some clinicians will ink craniocaudal mediolateral with different colors just because, to kind of get that frame of reference. And then there's others like me, when I will only do different colored inks if I'm particularly interested in having the pathologist take a look at that site. So to me, that ensures that is an area that's going to get cut in. Whereas if you mark multiple different areas, probably not going to get to look at all those spots. It's a slightly different approach.
Okay, thanks everyone. We've got a question from Dr. J. Kohler as well. Many of us are currently saying in our comments, the tumor appears fully excised. If we don't say this, we will get non-stop calls, but do you all think we should start moving away from this?
Rob, you got to go first. I hope.
So I can say from a clinician perspective, personally, I do think yes. From my perspective, I think it should be, here's the distance and make your own judgment, because, my concern is often, let's say, for example, with a mast cell tumor that we take proportional margins, sometimes I'm not expecting a significantly large margin in that case. And so then having someone say, it's incomplete because there's less than a centimeter of clean tumor-free tissue can get confusing. So I think from a reporting perspective that it ultimately should be, comments about encapsulation, comments about crossing boundaries, comments about distance are very important. But I personally find it a bit challenging when there's comments specifically about completeness of excision, because I think clinically that doesn't always correlate with what's seen histopathologically. And that's where the disconnect is also maybe in the way that we educate veterinarians. And so it's not to say that it's the pathologist's fault as much as it's unfortunately often the ones who are kind of interpreting that report.
It sounds so litigious to me if they ask me, is the excision complete or not, Don? Oh my goodness, I would refer them to Rob Foster and say, well, that's going to go back to the clinician. They'll decide if it's completely excised. But I can see their perspective with this, and maybe it'd be interesting to hear from Richard or Eliza at companies. How are you going to handle that when your consumer, when your client says, well, is it complete or not?
I never, like, unless it's a benign tumor, I almost never say complete excision anymore. I give my mitotic count. So Don, you trained me on that. I bought into the Kool-Aid. I'm 100% with you. I give that. It's a flat number. It's 2.3 millimeters squared. That's what I give. And I give the millimeter margin. That's it. And if I have any hedgy comments on it, I tend to be a lumper and a pretty definitive person. But if the tumor type or the sample or anything else is making me have concerns, I'll say, please see comments. And the first part of my comments is about my concerns. But otherwise, I just leave it flat out. I get maybe 1 or 2 calls a week at most. So.
Well, whoever asked the question is probably a pathologist. Can you reverse it and say, well, what do you do?
I'm going to wade in here too, because I don't know, fools rush in. I've actually thought about this a lot, because when you write procedures and guidelines, and when you approach it from a perspective that what can you prove in the literature? The challenge with saying something is complete as a pathologist, I think you're on very shaky grounds. And you know, complete excision, that kind of terminology, I think you're on very shaky grounds. And I'm sure in the companies, if you went along to your legal department and you say, I'm making recommendations and I'm actually just blowing wind, they would not be particularly friendly, would be my guess. So I think it's possible to mitigate this. And one of the ways of mitigating it is to actually come out and say, is to say what is published, and say the recommendations, you know, give them the link to the VCGP website, any other materials that you haven't. And I've now got a standard kind of, I've kind of got a standard comment that I send to people when I'm asked about this, and you know, in some ways I've got luxury because I've got the time to do this, but I think in your reports you can mitigate it. I don't ever remember saying margin complete, margin, you know, I'll say neoplastic cells at margins, but I've never said excision complete. You know, everything is, I don't actually use that terminology, and I'd never have. And I think in many situations as pathologists, as a group, we have brought this on ourselves by trying to be too helpful in situations where we really don't have the information. So that's where I'll leave it.
Yeah, Rob, I'll be a fool with you, and I'll confirm that. I think at least at diadex, we do have guidelines to say let's just be as factual as possible. There are some things that can't get away without us interpreting like what is a diagnosis, right? But there are other things that we're talking about here. What is objective that we can measure, or what is semi-objective? And I think that's part of the standardization is, again, less than 1 millimeter may mean something for one tumor, and may not mean something for the other, right? Do I know for every single situation for every individual animal out there? No. So I think if we can kind of stick to what's published, and what's published is, if I give you a number, you should be able to look up as a clinician what that means for your tumor. I mean, a lot of that onus should be on clinicians. You're right. Oftentimes we're being too helpful, but sometimes we get burnt on that as pathologists. And so a lot of times I think that's where at least a lot of the guidance at diadex, and I'm pretty sure at all the other major companies, we've learned through trial and error, through legal actions, and not, what we can and what we should and shouldn't say. And I think it's a minefield, but I think that's also part of why we're talking about this, right? We don't want to get people in trouble. We want to set the right expectations. There are some things that I think should be well within our influence to control and to comment on, and there are other things that I think, let's just report the facts.
I'd throw out two other comments, that there is a fork in the road between primary care veterinarians and then our oncologists. So the oncologists, I suspect, they're not going to ask us that question. The primary care veterinarians will, and the primary care veterinarians, I think we got them hooked on our comments, and that's too bad. So they do expect some of this information, and I've had them say to me, no, don't stop the comments. I need some of that information when I go talk to the client. Well, Michelle doesn't need that. Ryan doesn't need that, and I'm embarrassed to think that I should put that down there for them. But it does point out in vet medicine, vet path, vet oncology, we've got two different clienteles who we're providing this report to. I was associated with a lab, and it was started by an MD, and we did it for animal tumors, animal cases. CBCs and urine were the bed money earners, but we did histopath. And Ted, who was just super, he said, we don't put comments like you do in our medical reports. And one of the reasons is if someone did not, the clinician, follow up and do what the pathologist suggested, then you've opened the door to, why didn't you do what the pathologist suggested? He recommended a molecular test or some other test. So Ted was very anti adding too many of these comments, especially if they weren't backed, as Rob would say, by the literature. So I want to back up. I think we've got a good idea with the standardization, but you can't standardize everything. There's always going to be some cracks, or there will always be situations such as this where you can't standardize it for the profession, but it'll fall back on the individual lab or individual pathologist philosophy on how they're going to handle it. And I'll be stopped there. Thanks.
I can certainly see the fork in the road and the difference between, general practitioner's assessment versus an oncologist. But one thing maybe to consider, if you are reporting, that the margins are complete, just kind of having a statement to qualify, what you did in order to make that determination, how many sections were cut in, and then just remind the clinician to interpret that finding in light of, how little of the actual specimen you evaluated, because I think it is really easy for clinicians to kind of just interpret those comments in a vacuum, like I mentioned in a portion of my talk. And then, they think, okay, I can have an easy discussion with the client. I don't want to think about this anymore. I'm on the phone. I'm making the call. I'm on to the next. And so just kind of do something to remind them, to evaluate that in light of what they did at the time of surgery, and to remember, kind of the details of how the process works.
Okay, great discussion. Our next question is from Laura Romero, who asks, what can you comment about the invasion of nerve fibers by tumor cells?
I hope Jay Kohler is still listening.
Well, I guess I'll make a comment that I can't comment at all because I've heard about this, but I don't think I am I don't have any experience really in saying what it means and what it means for animals in particular. I have in a past life in my lab animal days, this was a thing for a certain research study, but it was a very different mechanism of how it invaded. So, I guess I just can't claim that. I don't know of any studies in animals that really talk about nerve fiber invasion by tumor cells. So maybe someone else does.
Laura, if you can respond to the person who asked the question, ask them to send us a reference or to clarify what they were going after. It might be very interesting, but I'm like Richard, I don't have any insightful comments. I would love to see a reference on it.
There's some human studies on it, and one of them says this is a severely understudied section of pathology. So I think we've got a long way to go.
Yeah, I mean, I have an extremely minimal experience with it. Have seen a couple cases of neurolymphomatosis in dogs, but it's very rare, and there's not much to say about something that you've only seen once. So yeah, I think it's hard to comment on.
Yeah, it's I'll make a comment because I seem to have this ability to click on my mouse with my mouse on the unmute button here. I've seen a number of these. I'm certainly aware that they are a big feature of pancreatic carcinoma in humans, and they are thought to be responsible for a lot of the pain that occurs with pancreatic carcinoma in humans. Not that carcinomatosis itself wouldn't be very painful, but it happens so infrequently that I think it would be very difficult to have any kind of study with any meaningful numbers. And usually the ones that get into nerves also are within blood vessels, so they have vascular invasion. And in terms of metastatic spread, from a purely a theoretical point of view, lymphovascular invasion and carcinomatosis is way more important in terms of spread than along a nerve.
Yeah, I feel like all of us have had like a handful of cases, in our careers where we can look back and go, oh, look how crazy, it's all up in the nerves. And then we just sort of refile the slide and don't think too much about it. And, I think probably, again, all of us have, 3 cases or something. So we all need to get together, I guess.
I think Laura Ramirez just popped a reference in the chat if anyone was interested in looking at it at some point, because I think that's all the questions we've had at the moment. So I'm not sure if anyone on the panel had any final thoughts or parting thoughts that they wanted to share before we end the session.
I would, Laura. I want to thank all the speakers. I think they did a great job. I learned from those as well. And I got to compliment the folks who send in these questions. It makes me proud to be a veterinarian and to hear so many good queries that came in. So I appreciate all those. And you did a super job too, Laura. Thanks. Everybody have a good weekend.